We begin with next important topic, that is the management of ovarian hyperstimulation syndrome. It is a green top guideline number 5. Okay, this guideline is going to be very, very important from the examination point of view, as it is a GTG very frequently asked. Always there is either SBA or EMQ from this particular uh, GTG. Okay, so it is important from part 1, part 2, as well as part 3 point of view also. So what exactly we are going to learn in this GTG is how to identify the patients and the cycles which are at risk of OHSS, and how to apply the preventive measures. Then what are the triggers of OHSS and etiopathogenesis? What are the types of OHSS? And severity classification, differential diagnosis, whether they are to be treated on outpatient or inpatient. Okay, and your SBA EMQs will be based on this. One is the severity classification, with what is the severity of this OHSS. Okay, and whether she will require outpatient or inpatient management. Then management indications for paracentesis and indications of surgery we should know, and what are the regulations for reporting to HFEA, and who is supposed to uh, inform. Okay, so that is what we are going to see today. So OHSS is most significant short-term complication associated with ovarian stimulation. It is iatrogenic and potentially severe complication. Okay, mild OHSS is seen in 1/3 of the cycle. That means almost 33% is the incidence of mild OHSS. Remember this, it can be asked in the SBA. And this percentage is of mild OHSS, not the moderate or severe. Moderate or severe OHSS is responsible only in 3.1 to 8% of IVF, and reporting is only for severe to critical cases of OHSS to HFEA. So HFEA is a Human Fertilization and Embryology Authority. Okay, so they all cases of severe and critical are to be reported to HFEA, not the mild and moderate. So OHSS has got a 4 grades, okay, or severity classification into 4 types. It can be mild, moderate, severe, and critical. Okay, so these are the 4 types of OHSS, out of which the severe and critical needs to be informed to the HFEA, that is Human Fertilization and Embryology Authority. Okay, so that can be asked as in one of the EMQ option. Okay, so OHSS is characterized by the ovarian enlargement, increased vascular permeability, and fluid shift. So this is what is the triad which you see: ovarian enlargement, increased vascular permeability, and the fluid shift. Okay, so which patients are at increased risk of OHSS? If the patient is young, PCOS, then previous history of OHSS, use of GnRH agonist, and high MH levels. Okay, so if these patients are there, in those you think of that they will be at high risk of OHSS. And during stimulation, there will be high estradiol levels, sudden rise in estradiol, high follicular count, and increased number of eggs will also indicate that these patients are going to land up with OHSS. Which patients are at low risk of development of OHSS? If you use GnRH antagonist instead of agonist. If you go ahead with the coasting of overstimulated cycle, what you do in coasting, you stop the stimulation but continue with the pituitary suppression. Okay, so there is a atresia of the small follicles, and these small follicles actually are responsible for creating this pathophysiology of OHSS. Okay, and patients who are on metformin in women with PCOS and dopamine agonists, so these patients will be at low risk of the development of the OHSS. Okay, OHSS is likely to be more severe and prolonged in cycles where the conception happens. Okay, so outcome of the cycle is also very important, because if she becomes pregnant, then OHS is likely to be more severe and it will be lasting for a longer time. Okay. So what is the relevant history that we should ask? Okay. Uh, sorry. So relevant history from a woman suspected to be suffering from OHSS. So we need to ask about the time of onset of symptoms relative to the trigger, medication which is used, whether it is SCG or GnRH agonist, the number of follicles on the final monitoring scan, number of eggs which were collected, where the embryo is replaced and how many, and polycystic ovarian disease was the diagnosis or not. Okay, then symptoms will be abdominal bloating, abdominal discomfort, pain, need for analgesia, nausea, vomiting, breathlessness, inability to lie flat or talk in full sentences, reduced urine output, leg swelling, vulval swelling, associated comorbidities such as thrombosis. So these will be the symptoms of this patient. So clinical features will be given, and then the management or the question will be based on that particular scenario. Okay. So this particular slide is going to be very important, especially about the classification of OHSS. They'll give you the complete scenario, the description, and on the clinical features, we have to decide in which category it fits. Okay. So here there are two or three things which I'll say. One, look at the size of the ovary. And second, look at the hematocrit and other clinical features to classify this into mild, moderate, severe, and critical. Another thing we have just noted that severe and critical will require a reporting. Mild and moderate will not require reporting. Mild have a prevalence of 33%, while moderate to severe has got a 3.1 to 8% prevalence. Okay. Now, mild OHSS, there will be just abdominal bloating, abdominal pain, and ovarian size is less than 8 centimeter. Okay. Then you have a moderate OHSS in which there will be moderate. So pain is increased. There is a nausea, may or may not be associated with vomiting. Ultrasound evidence of ascites and ovarian size is generally 8 to 12 centimeter. Okay. So it is a USG evidence of ascites, not the clinical evidence. So if you have got a ascites which is seen on ultrasound and ovarian size is up to 12 centimeter, then we are dealing with moderate OHSS. Okay. So read the scenario very carefully. Then severe OHSS, here the ovarian enlargement will be more than 12 and ascites will be clinical ascites, may be associated with hydrothorax also. There will be oliguria, hemoconcentration, hematocrit will be more than 45% and there will be hypoproteinemia. Okay. And in critical OHSS, there will be tense ascites. Okay. So here onwards the clinical ascites, but here it will be tense ascites. There will be large hydrothorax. Here it was occasional hydrothorax. Here it will be large hydrothorax. Hematocrit will be 55%. Here it was more than 45. It was a 55%. TLC will be more than 25,000. Oliguria or anuria, thromboembolism, and ARDS. Okay. And another thing is that one more thing you just remember, ovarian size may not correlate with the severity of OHSS in cases of assisted reproduction because of the effect of follicular aspiration. So if the follicular aspiration is done, then the ovarian size may not correlate. So even if you may have a ovarian size of 10 centimeter, but you need to look into other features to classify it into the appropriate type. Okay. So I hope this is clear to you. Okay. Now, HFEA
Yes.
reporting, that is a Human Fertilization and Embryology Authority. This also we have discussed which patients severe and critical we are going to report. Then who is going to report the fertility treatment where the treatment is carried out, that center will report, not the place where the patient is getting the treatment for OHSS. See, most of these fertility centers, they work on a daycare basis. It is not a 24/7 service. So you will be guiding the patients to get admitted if there are certain symptoms which are available. Okay. So the patients will go to that particular hospital. Okay. So from that NHS hospital, the appropriate fertility center will be informed, and that fertility center will be informing to the HFEA. Okay. So reporting will be done by the fertility clinic. Okay. So fertility clinic should provide verbal and written information concerning OHSS to all women undergoing fertility treatment, including 24-hour contact telephone number. And women presenting with symptoms suggestive of OHSS should be assessed face to face by a clinician if there is a doubt that the diagnosis or the severity is likely to be greater than mild. So if there is a even telephonic inquiry, and if you feel that it is going to be more than mild, then call for the face to face interview. Okay. Then there are two types of management. One is outpatient management and second is inpatient management. Okay. Critical will always be inpatient. For critical case, there is no OPD management. So most of the cases of mild and moderate and some cases of severe may be managed on the OPD basis. Remember, few cases of severe can also be managed. However, the patient should be compliant for the follow-up. Okay, so mild to moderate OHSS and selected cases of severe OHSS will be given OPD treatment. Outpatient management will involve the counseling and providing the information regarding the fluid intake, output monitoring. In addition, they should be provided with the contact details to access advice. NSAIDs will not be given, okay, because they compromise the renal function. Women with severe OHSS being managed on OPD basis should receive thromboprophylaxis. Okay, so even if they are on OPD basis, those who are severe but managed, they will receive the thromboprophylaxis. The duration of the treatment should be individualized, taking into account risk factors and whether or not conception occurs. Then paracentesis of the ascitic fluid can be carried out on OPD basis by abdominal or transvaginal route under the ultrasound guidance. So this is sometimes SBA or EMQ is asked. They will give the clinical features and they will ask the next step. If the patient is compliant, it will be on a OPD basis management, and the next step will be the paracentesis. Okay, then that can also be carried out on OPD basis as well as indoor cases. Okay, there is insufficient evidence to support the use of gonadotropin releasing hormone antagonist or dopamine agonist in treating established OHS. So once the OHS happens, after that GnRH antagonist or the dopamine agonist do not have role. So they may be before OHSS. If the patient is receiving this drug, generally there is a low risk of OHSS. But once there is established OHSS, this is not a curative treatment. Okay, women with OHSS being managed on OPD basis should be reviewed urgently if they develop symptoms or signs of worsening OHSS. In absence of these, we will call her for follow-up every 2 to 3 days. Okay, baseline lab investigation should be repeated if the severity of the OHSS is thought to be worsening. Hematocrit is a useful guide to the degree of intravascular depletion. Okay, so these are the things which we need to work it out. General examination, abdominal and respiratory, we need to look into it. Then investigations will be full blood count, hematocrit, CRP, urea, electrolytes, serum osmolality, LFTs, then coagulation profile, SCG, and ultrasound scan for ovarian size, pelvic and abdominal free fluid, and we may have to do ovarian Doppler if the torsion is suspected. Okay. Other additional tests such as ABG, D-dimers, ECG, chest X-ray, and CT angiogram or ventilation perfusion scan, depending upon the indication. Okay. So what is the monitoring? If the patient is admitted, that is the inpatient management of severe OHSS, you have to do daily weight, abdominal girth, input output, full blood count, hematocrit, electrolytes, liver and renal function test. Okay, as indicated by clinical features, we'll do the pelvic and abdominal and chest ultrasound, ECG, blood gases and chest X-ray. Analgesia, you will avoid the NSAIDs. Consider other causes of pain such as torsion or the ectopic pregnancy. Fluid balance, it is always you have to encourage the oral intake to the thirst. Okay, and crystalloids for initial dehydration can be used. Colloids for the volume expansion, and consider paracentesis. Avoid diuretics. Thromboprophylaxis is required. LMWH is used. Mobilization, be aware of the atypical presentation with arterial thrombosis and upper body involvement. This is very typical about OHSS. In OHSS, what kind of thrombosis you get? You do not get lower limb. There is a high incidence of the upper limb thrombosis, and they are arterial in nature and not the venous. Okay. Then third space fluid collections. The treatment is a paracentesis of the tense ascites, drainage of pleural effusion. Surgery is indicated only if there is a torsion or the ectopic pregnancy, and intensive care is required for critical OHSS. Okay, so that is what is the inpatient treatment. So hospitalization indications also we are supposed to know. So if the patient is unable to achieve the satisfactory pain control, if the patient is not able to take orally due to nausea, if there are signs of worsening of the OHSS despite of outpatient intervention, if the patient is unable to attend regular OPD follow-up, severe critical OHSS, and multidisciplinary assistance should be sought for the care of women with critical OHSS and severe OHSS who have persistent hemoconcentration and dehydration. Okay, so these were the indications for a hospital admission. Okay. So those who are on OPD but getting worsen or not getting control because of the pain or intake is less, and critical will always require admission, and non-compliant patient or those who are cannot follow up on OPD basis will require the indoor admission. Then clinical monitoring and inpatient management. Women admitted with OHSS should be assessed at least once daily. More frequent assessment is appropriate for women with critical OHSS and those with complications. Analgesia and antiemetics may be used in women with OHSS, avoiding NSAIDs and medicines contraindicated in pregnancy. Okay, so fluid replacement by oral route guided by thirst. Okay, that is the most physiological approach for correcting IV dehydration. If there is a persistent hemoconcentration, in spite of volume replacement with IV colloids, may need invasive monitoring, and this should be managed with the anesthetic input. Diuretics are to be avoided. Okay. What are the indications of paracentesis? If there is a severe abdominal distension and abdominal pain secondary to ascites, there is shortness of breath and respiratory compromise secondary to ascites and increased intra-abdominal pressure. Oliguria despite adequate volume replacement, secondary to increased abdominal pressure causing reduced renal perfusion. So if there is a severe abdominal distension, abdominal pain, shortness of breath, respiratory compromise, oliguria in spite of adequate volume control, then that will also reduce the renal perfusion. Go for paracentesis. Okay. And paracentesis is generally there is a scenario and the paracentesis is an option. So you look for that kind of picture. Okay. So paracentesis should be carried out under ultrasound guidance and can be performed abdominally or vaginally. IV colloid therapy should be considered for women who have large volumes of fluid removed by paracentesis. Okay. Then regarding VTA risk, these patients will require LMWH prophylaxis, and that is needs to be individualized according to the patient risk factors and outcome of treatment. Women with moderate OHSS evaluate for predisposing factors for thrombosis and prescribe either anti-embolism stocking or LMWH. And those where we suspect VTE in women with OHSS or who present with unusual neurological symptoms, even if they present several weeks after the apparent improvement in OHSS. So you need to suspect VTE in these patients even after a substantial duration. Also, they can have the VTE. Okay. Indications of surgery will be adnexal torsion, ovarian rupture, and the ectopic pregnancy. It should be performed by experienced surgeon. Antenatal risk. This also you should remember. If the patient is OHSS, there are two risks. One is a preeclampsia and another is a preterm delivery. Preeclampsia risk is 21%, that is 1 in 5. Okay. And preterm delivery is around 36%, that is 1 in 3. Okay. So these two risks are increased in patients with OHSS. Then coming, what are the prevention strategies for the OHSS? One is optimize the weight. If the patient is obese or underweight prior to the ovulation induction, you always optimize the weight. Second, go for low dose step up protocol with gonadotropins, has lower risk of overstimulation and cycle cancellation than the step down protocol. Okay, so low dose step up protocol with gonadotropins. Then third is a coasting, that also we just discussed, that during IVF cycle, in cases with excessive response, you will stop the gonadotropin injection and continue the pituitary suppression. That will lead to the atresia of the small and intermediate follicles, while larger follicles, which are independent of FSH, that will continue to the grow. And how this acts, it will reduce the granulosa cells producing vasoactive mediators such as VEGF. Okay, so this VEGF, vascular endothelial growth factor, that is responsible for all the clinical features. Okay, once serum estradiol is decreased to a safe level, that is less than 3000 picogram per ml, final follicular maturation is induced and proceed with the trigger. If ovarian response is not settled in 3 days, then you need to cancel the cycle. Okay, use GnRH agonists for endogenous LH surge in the antagonist cycle. So if you are using antog cycle, that is the antagonistic cycle is there, then GnRH agonist you can use for the LH surge. Okay. Then use progesterone for the luteal phase support, which is quite effective as SCG. This is a question in one of the book. Okay. GnRH agonist for the LH surge in antagonistic cycle. Okay. Then this is what we have discussed. One is the choice of treatment, ovulation induction in IVF regimens. GnRH antagonists are preferred. Costing can be done, and triggering oocyte maturation with GnRH agonist in antagonist cycle. Then single embryo transfer, blastocyst transfer, and elective cryopreservation, luteal phase support, SCG versus progesterone, other agents such as metformin, dopamine agonist, and cycle cancellation. So these are the modalities. So take home message is that incidence overall is 1/3 of the cycle for mild, moderate to severe 3 to 8%. Vasoactive substance is VEGF, responsible for the clinical features. Early OHSS, there are two types of OHSS. One is early and another is a late. Early generally happens within 7 days of the trigger. Few books mention up to 9 days. Okay, as per the talk, it is 9 days. As per the GTG, up to 7 days. Okay, due to exogenous SCG, less severe as compared to the late OHSS. Late is more severe. So late OHS happens after 9 days due to the endogenous SCG. So the reason for early OHSS is a exogenous SCG. Reason for late OHSS is the endogenous SCG produced from early pregnancy. Late OHSS is more severe than the early OHSS. OHSS is a dynamic condition and level of severity may change over time, and hence clinical monitoring and counseling of warning symptoms must. Generally, pain in OHSS is mild. With severe pain, we need to think about other differentials such as ovarian torsion, ectopic, we need to rule it out. Then VTE preponderance is related to the upper body sides, and there is a frequent involvement of the arterial system like carotid or vertebral artery occlusion leading to ischemic stroke. VTE risk is around 0.7 to 10%. Late VTE can also occur even after the resolution of the OHSS with visual and neurological symptoms. Okay. LMWH prophylaxis for critical and severe cases. Moderate cases assessment is required and anti-embolic stockings or LMWH. But in severe and critical cases, you will go ahead with the LMWH. And first trimester, if the patient becomes pregnant, you will continue the LMWH throughout the first trimester. Okay, so that finishes an important GTG about the ovarian hyperstimulation syndrome.